Hello, I'm absolutely delighted to be joined here by the winner of the cardiac section of the instructional video. It was a wonderful video. It was a unanimous decision. Vince Codiani particularly absolutely loved it, even rang me up to tell me all about it. So, of course, it was the wonderful Anthony Zaki. We actually met in the Cleveland Clinic when you were dashing around, saving lives, putting impellers in, doing transplants. You do a huge amount there, and somehow you have time to edit a video. But it was an absolutely brilliant video. So maybe just maybe tell us a little bit about yourself and what you do at the Cleveland Clinic, and then tell us all about this video.
Great. Well, thanks for the opportunity and for selecting my video. My name is Anthony Zaki. I'm here at the Cleveland Clinic. I'm a cardiac surgeon with a specialty focus in heart failure, mechanical circulatory support. I grew up in Michigan. I went to medical school in Chicago and did all my training and all my cardiac surgery kind of experience has been here in Cleveland. So it's a great place to work and I love it here. Yeah, that's what I do. And kind of the thought behind the video was trying to make Impellas more accessible, trying to, we noticed all surgeons out there are noticing that the patients are becoming more complicated and higher risk and have a lot more baggage attached to them. And so the thought behind the video was kind of empowering surgeons, especially surgeons like me who are early on in their career, and to take on these cases and have that support to get them through. So that was the inspiration behind the video.
Yeah, now the video does a really good job of telling us about the balance between a balloon pump, an ECMO, and Impella. So maybe just start about where you see the Impella fitting in between these range of options for surgeons.
Yeah, so the Impella is it's a very versatile device. Especially, we're talking mostly about the Impella 5.5 for left-sided support. It completely unloads the left ventricle. It's easy to put in. It's easy to remove. I think the balloon pump is kind of that tried and true surgeon's first grab for, and I think there's a role for it. The cardiologists and those who deal with acute MI shock and who are in a kind of a slightly different world, they've mostly written off the balloon pump. But I don't really. I think for the cardiac surgeon, we still have a role for it, and I'm glad it's still on the shelves and we grab for it every once in a while. But for that patient with severe LV dysfunction or stunning post-pump, the Impella is really effective at unloading and keeping that ventricle empty, and I think it gives you the best chance at LV recovery. So it's become more and more part of our our toolbox for these complex cases where you think there's going to be some post-pump LV dysfunction. That tried and true ECMO is the surgeon's best friend. It's still a role for that as well, and we reach for it frequently if needed. The point of the video wasn't to say the Impella is the only option, but just to make it one of the options. And I think there is an inertia that a surgeon has to overcome to reach for an Impella, saying, well, that's something new, I don't understand it, or I'm not comfortable with it, or don't know how to put it in. And so the point of the video was to try to overcome some of those barriers to give, a surgeon just one more thing they rely on, one more tool to rescue a situation and, help save a life. So that was the inspiration and the thought process.
Yeah, no, you do a really good discussion about that, the balance of an Impella versus those other two great therapies. But I guess the best thing about this video is your fantastic description of the direct aortic approach, which looks absolutely, fantastic. And, if you just think about it, it sounds really scary and awful, but actually the way you've demonstrated it on the video is beautiful. So maybe just describe a little bit, how you do direct aortic approach and why that might be better than some other approaches.
Yeah, I mean, we identified that one of the main barriers to an Impella placement was access. That after a long operation and your patient's coagulopathic and, there's some LV dysfunction or RV dysfunction, and is that, well, do I really want to embark on an axillary cut down right now? I think a lot of surgeons, there's a varying degree of comfort with axillary artery exposure. So the aorta is right in front of you. And so what we describe in the video is putting a side biter clamp on the distal ascending aorta, sewing a 10 millimeter graft end to side. The anastomosis just takes a few minutes. It's just like any coronary anastomosis. And there's your access right there. And once you have the access, we tunnel it out to either the right neck or the left neck. My preference is the right side. I think it has the Impella lie a little easier. It's a little easier to cross the valve as well. And then we just float the device in a similar way as we would for any axillary Impella. So, yeah, there are some limitations, though. You need to have a long enough ascending aorta to accommodate the device. So the official recommendation from the device company is 7 centimeters from aortic valve to base of the innominate, or from where your anastomosis will be. And that is a common area. Some people have some innominate calcifications right at the origin there as well. And so you don't want to be putting a side biter on some atheroma. And there are cases where we, with the clamp on, will be putting this 10 millimeter graft on if we feel like the situation demands it. So the main advantage of the approach is that the aorta is right there, and it's already it's right in front of you. So take advantage of it, and you don't need fluoroscopy because the path from insertion from access site to where it needs to be is quite short. A lot of people don't even use a wire. I describe a way in the video of using a catheter and a wire to cross the valve, but you don't need that. You can just cross the valve with the pump directly, and a lot of surgeons do it that way, which is fine.
Yeah, I mean, it's just beautifully described. You've got your echo with Smart Assist, which is nice, and yeah, this is a really good technique, and I guess super easy to take out as well, isn't it? So,
yeah, that's the other advantage. We can take these out in the ICU. We don't need to heparinize, especially if you're worried about bleeding post pump. So we literally pull the pump, we ligate the graft, and we tuck it back into the mediastinum, and that graft, that column of blood, will thrombose. And we've gotten CT scans on these patients down the road, and that column is already thrombosed. If you get a scan early enough, you may see a little bit of an outpouching. This the radiologist may call, a distal ascending aortic pseudoaneurysm. But if you repeat it in a few weeks, it'll be completely gone. So it's real easy to take out.
And I guess you could potentially wake a patient up if it's suitable with this in the neck. Is that something you do sometimes?
We routinely do that. That's I think the main advantage over ECMO is that we can get these patients ambulating. We wake them, we extubate them. Day 0, kind of our normal ERAS pathway. We get them out of bed and walking, and similar to an axillary Impella, there's really no limitations post-operatively.
Yeah, well, it's absolutely fantastic. What a brilliant video! And after this interview, what are you going to be doing this afternoon in the Cleveland Clinic?
We are putting a patient on an Impella pre-transplant. So Impellas every day, all day. So we have a patient who's status 2 waiting for a heart. So we're going to be upgrading his balloon pump to a right axillary Impella 5.5.
Anthony, thank you so much for this awesome video. I think hopefully up next year you might even submit some more content, maybe on some VADs and ECMO and things. But what are your thoughts for the future as a final closer?
Yeah, I'm happy to provide more videos, more instructional content. Try to break down barriers and make these things more approachable and easier to deal with. So yeah, we could do mechanical support and anything along those lines. Whatever you guys are looking for, happy to provide.
Amazing. Well, thank you so much. You guys at the Cleveland Clinic provide so much leadership and teaching around the world. It's really amazingly appreciated. So from all of us at CTSNet, thank you so much.
Take care. Thank you for the interview. Appreciate it.